Good morning and welcome back. We were talking about IV fluids. I talked about basics, about the intravascular compartments and the extracellular compartment and the intracellular compartment. And we also talked about how crystalloids leave the vascular compartment very fast because they are basically small molecules, and now colloids still stay there. Now we will be discussing each crystalloid, and further down the line we'll also touch upon the colloids. We talked about crystalloids as a group. Now we are picking up the common crystalloid solutions used, and we will be giving, and I will be giving a brief on each. So today will be the normal saline. Ideally, it is to be called the isotonic saline. You will understand when we go further down the presentation. Now, what do we look for? See, this is a very common bottle. We just open it without idea what we are holding in our hand and how it's going to impact the patient's physiology. More so, the patients who are very sick, their physiology is very frail in the ICU, and we open these bottles basically without much knowledge about what exactly are we pushing into the patient's system. So this, I want a little bit of clarity. It is not that difficult. It can be easily clarified, and you can take home the messages. So what is my brief? The true impact on the intravascular volume. We had talked about colloids and crystalloids. Crystalloids stay only 25% in the intravascular volume. The rest will go into the interstitial space. Now, what I wanted to tell was that doesn't mean you will not give normal saline. It's being given. But you must understand that only 25% is going to be there. Now, there may be very small, there may be instances when you can tide over the volume deficit by giving normal saline. 25% will remain there, 75 is going to leave, not within an instant, it's going to take more than 2 hours. Meanwhile, you can arrange for fluids, you can arrange for surgery, or the body itself will use its homeostasis to sort out the issue. It all depends on the clinical scenario. So that is the intravascular volume. What does it do to the acid-base balance? We'll come to it as we progress down the presentation. And the impact on the interstitial edema. So this solution has a variety of names. It's called normal saline, physiological saline, isotonic saline. Actually, none of them are appropriate. It is not even isotonic. Fine. The term used for 0.9% NaCl in this text is isotonic saline. We will be using it because we want to differentiate it from hypertonic saline. So these are the various crystalloids all lined up by a very good postgraduate student of mine called Dr. Fahim from PIMS. He has arranged up these bottles and taken a photograph and sent to me long time back. So I must thank him. Thank you, Dr. Fahim. Okay, the next will be India. In India, the saline solution market is quite a bit. That's because it's being used. It's not that because I pointed out the disadvantages or the problems that you will stop using it. There are enough benefits. Only thing is, nobody will ask benefits. They will ask you the drawbacks of normal saline in your when they test your knowledge. So this is the composition of your isotonic saline. But be very careful. This is for 1 liter. It's not for 500 ml. It's always the milliequivalents are calculated for 1 liter. So it's 154 and 154. Your bottle will be containing only 77 millimoles. What happens? They will give you a bottle in NEET and give this figure. This is for 1 liter. So be careful. But if they mention that the constituents of normal saline is 154 millimoles, you assume it's 1 liter if it's a text. But if they show you a bottle and ask you the amount of milliequivalents or millimoles of sodium in this bottle is, please choose 77. That is very important. Now, what I wanted to tell, Between milliequivalents and millimoles, there's not much difference as far as clinical practice is concerned. This millimoles and milliequivalents have a lot of difference when you're talking about very pure chemistry and you're talking about experimental physiology. But when it comes to day-to-day patient management, this millimoles and milliequivalents, we are using it as alternate for each other. So there's no big difference. And of course, the osmolality is 308. We'll come to it. It has an impact. We'll come to it later. So 0.9% sodium chloride is called normal saline. As I told you, this solution is neither chemically normal nor physiologically normal. It does not match the plasma. Now, what I want to tell you is just have a look at the plasma and look at the NaCl. You have very high levels of sodium and chloride. You hardly have any of these electrolytes, and definitely you don't have a buffer, which is very, very important. That is why the pH is acidic. Not only that, this chloride is the one which is making it acidic, because chloride is an anion. Sodium is your cation. This is your anion. And if you know this is acidic, one, because the chloride content is more, and number two, there are no buffers in this solution. And number three, osmolality is very high because the milliequivalents here are very high. So you must understand the pH is very low when compared to plasma, and the osmolality is very high when compared to the plasma osmolality, and the sodium and potash and the chloride concentration also. Now, why can't it be called normal? Because you should have 58 grams per liter for it to be called normal. They are the molecular weights of sodium and chloride. But this has only 9 grams. So it cannot be called normally in the chemical sense. Why can't it be called normal in the physiological sense? It cannot be called because of these two differences, or rather the three differences. So as I told you, again we are going back. You give 100 ml of crystalloids. Any crystalloid you give, only 25% will stay in the intravascular compartment, 75% will go into the interstitial compartment, not inside the cell, in the interstitial compartment. Now there is an unexpected finding. You gave only 100 ml. So this plus this should be 100 ml, but it becomes 110 ml. Why? Because the sodium here is hyperosmolar when compared to the intracellular. So it will pull water from outside. So 75 plus 25 should be 100. No, it becomes 110. So there is 110, there is a big amount, not only 75, but some more amount sitting here. Now that cannot go back into the cell. It will take the water and stay here. Neither the sodium can enter here nor here. It will be parked here and causes all the issues. So it leads to edema, interstitial edema. See, this is what happens when you have a pulmonary edema. There will be lot of fluid in between the cells in the interstitial area. When the pressures go very high, they will enter the cells, which is your alveoli. So very important problem is pulmonary edema. Your bowel wall will be edematous, especially when you have done resuscitation in trauma and there is a bowel injury. You are trying to anastomose a bowel injury which is edematous. It will break down. So these are the lot of follow-outs because the edema has set in. So this is the idea. Interstitial edema is a big problem with high volume resuscitation with sodium chloride. Not just the limited volumes, but high volumes. When you have to give high volumes, you cannot use normal saline. In fact, according to the ATLS protocol, I am a surgeon, so I will know trauma resuscitation. I may not know medical resuscitation much, but when it comes to trauma resuscitation, the ATLS guideline is very clear. It is renal lactate, which is the immediate fluid of choice. Now, this edema itself can reduce renal perfusion. The renal mediated injury may be also coming from the chloride ions. So you see a lot of things happening there. Now, it doesn't mean you have to decry sodium chloride and take it out of clinical practice. No, you need to have it, but you also need to know the issues there. Now, what about the acid-base balance? You see, high acid load is there. So naturally it will cause metabolic acidosis. That metabolic acidosis is because of the chloride ions, and there are no buffers here. Unlike the plasma, there are no buffers to handle this metabolic acidosis. The buffer which was there in the plasma is not there now because patient has lost blood. He is in shock. So that also will not come to try to buffer this. So patient will have acidosis. Now coming to the summary, normal saline is no more normal chemically. As I told you, you need 58 grams in 1 liter, but we have put only 9 grams. So it can't be called normal in the true chemical sense. Neither is it physiologically normal. So the ideal name is isotonic saline. Still it is not isotonic, it is hypertonic, but we have no other word but to call it isotonic saline. Only 25% will stay in the vascular compartment, 75% will be the interstitial compartment. Now it is hypertonic. So what will happen? It will cause a lot of edema in the interstitial space. Not only that, this sodium will again raise the hyperosmolar. Already it was hyperosmolar. The sodium trapped will raise it further and it will shrink these cells. So there is an intracellular dehydration. And intracellular dehydration coupled with an edema outside can be a lethal combination to set up various vicious cascades. So it causes decreases in the renal perfusion, which is usually chlorine mediated, and it leads to acidosis. This much is the summary. This is the brief about normal saline. And I hope I brought some clarity. Thank you all very much. And I hope I brought some clarity. Thank you for being there with me. This is applied physiology. This is not something clinical to show you images and keep you interested, but you need to know these things. I've tried to make it as simple as possible, and I've only handled the core concepts. You want to know more about this for your personal interest, I can recommend one book which is called Paul Marino's ICU textbook. It's an excellent textbook. I'll try to upload it into the Telegram channel, and whoever's interested can download it. It's a very simple book. They will talk, the cellular level will be talked so easily that even a first year student will understand the clinical implications. So again, thank you. Please do subscribe to my channel, raise your doubts in my channel, and please do follow my Telegram